I'm going to start off by talking a little bit about how we think about disparities in the United States based on a report from the Institute of Medicine that really tries to distinguish differences in care from disparities, with differences being differences in care received that make sense because of differences in comorbid illness or genetics or things like that, whereas disparities are differences that we really think of as being unfair. And they may be due to problems in the healthcare system, they may be due to problems of bias and stereotyping. But there's also one type of difference that I'll highlight today as well, which is differences in patient preferences that is felt to be one of these fair types of differences, maybe not a disparity, but I think one of the key issues is understanding why patients might have certain preferences, and if those preferences aren't adequately informed, then that actually could be a disparity as well. And then the other area that I'm going to talk a fair bit about is differences in the types of providers that patients see that could be driving some of these disparities. So we have some evidence in the States that certain patients who are African American or Hispanic or who are poor might see different types of doctors or get their care at different types of hospitals that may actually provide care overall to their patients that is less high quality than the hospitals and doctors that white patients or wealthier patients see. I think that both of these issues, both this idea of patient preferences as well as this idea of the providers where patients get their care, have important implications. First, as far as patient preferences, it's fine if an adequately informed patient decides to refuse therapy, but I think what we really must address is making sure that these decisions that patients make are well informed, that we have information that we can share with patients in a way that they can understand so that the decisions that they make are the right ones for them and fit with their values and preferences. As for providers, I think it's really key to understand whenever we see disparities, whether they're driven by where patients get their care or within provider disparities, which are the fact that maybe care is different even at the same institution, because the policy responses are different. You can either focus on improving the care given by a provider who provides lower quality care if the differences are between providers. If the differences are within providers, then you obviously need to work on improving care everywhere. Today I'm going to talk about two issues that are happening in the States that hopefully will have some impact on these disparities that we're seeing. The first is our health insurance expansion, the Affordable Care Act, sometimes called Obamacare, which was passed in 2013 and has expanded insurance coverage widely. In the States, we historically have had an unusual path to insurance, which comes through our employers for most non-elderly people. And because of that, a lot of people have been unable to afford or have access to health insurance. That has been changing, and we'll show a little bit of data. There's some other work that we're doing now to try to understand the effects of this insurance expansion, and particularly expansion of Medicaid, which is insurance for the poor, on trying to improve cancer care. Although that work is in progress and I won't be able to share any of that today. And then the second thing I'm going to talk briefly about is an experiment that is happening right now through our Medicare program to try to improve the delivery of cancer care to all patients, but hopefully by improving to all patients we'll also be improving on disparities, and we will be studying this. This is a policy that is changing the way that oncology practices are paid for their oncology care for delivering chemotherapy, where practices are getting fees to help with care coordination and management of care, and then if they achieve certain levels of quality and the cost of care for the patients that they're treating is lower than what might be predicted based on historical benchmarks, then they have opportunities to share in some of the savings with the government for taking care of these patients.